I'm a consultant neurologist in Edinburgh, and I've had an interest in cavernomas for a long time. I'm now finally got to the stage where I'm in a position to run a research study for patients not just in Scotland, but also throughout the UK. So it's been a very long journey to get here. I came to Scotland from London, where I'd been working at Neil's Hospital, the National Hospital for Neurology, in 1998. The intention was to set up an epidemiological study in Scotland to understand the outlook for people with cavernomas. And that study started in 1999. And then I've spent the last 20 years or so generating information about how common cavernomas are, what the outlook is for people with cavernomas, observing what happens with or without various forms of treatment for people with cavernomas. But really, the best way to find out what to do about treatment is in something called a randomized control trial. And with the support of Cavernoma Alliance UK, I'm absolutely delighted that we've succeeded in getting a reasonable amount of funding from a major UK funder to answer the top uncertainty for people with cavernomas. And I'll go into a bit more detail about that, but I just thought I'd start with who I am, where I come from, and why this is important to me. Neil, I'll hand over to you to introduce yourself too, and then I'll get on with the slides.
Thank you very much, Rustam. So I'm Neil Kitchen. I'm a consultant neurosurgeon, and I've stayed at Queen Square, so I haven't left, and I've been a consultant there since 1995, so that's quite a while. And although I did a lot of academic work to begin with, I've really concentrated on teaching, training, and examining neurosurgeons over the last generation, particularly with respect to intracranial surgery, that's to say what you would term brain surgery. But my particular subspecialty clinical interest has been cavernoma over the years, and as you kind of get on, you get increase in experience, and you get quite frequently not only de novo cases referred from local catchment area, but also other cases from elsewhere where perhaps surgeons and other clinicians require some advice and help. So I think I have a very large clinical experience, but it's been clear to me over the last decade or so that we need to not just rely on individual surgeons' experience and expertise, but we need to have more guidance about the treatment of cavernomas because of their innate variability and uncertainty. And I think Rustam's and my partnership is perfect in a sense, because we have his almost unparalleled experience and expertise in randomized trials and clinical large-scale population studies, with my access to the relevant neurosurgeons in the UK and thus their patients. So this has been a culmination of about a decade's work, and so we're both very excited that we're on the cusp of starting to randomize patients. So thank you all for listening, and I'll hand back to Rustam.
Thank you, Neil. So to build on the long-standing collaboration that Neil and I have got covering the two major specialties involved in the management of people with brain cavernoma, as you can see on this slide, the project involves a truly multidisciplinary group of people representing not only adult clinical specialists, but also those looking after children, people who are experts in the design of these randomized studies that I'll tell you about in a moment. We've got a fantastic trial manager from my clinical trials unit called Elaine Kinsella, who's running the project alongside us. We've got trainees involvement, so we're very keen to have a network of trainees in neurosurgery throughout the UK, looking out for people who would be eligible alongside the busy consultants they're supporting. And we've also got the involvement of not only Neil, but Matt Radatz, who are the people who lead the two centres in the UK who deliver stereotactic radiosurgery for people with cavernomas. And then we've got a lot of expertise in the running of trials in neurosurgery from Cambridge, both from Peter Hutchinson, who's done plenty of trials recently and in the past in the UK neurosurgical community, and Carol Turner, who helps him coordinate that. And then the involvement of some qualitative researchers from Bristol who are experts in understanding why people do and do not take part in research, and radiologists who are expert in reviewing the imaging of people with cavernomas. And last but absolutely by no means least, Cavernoma Alliance UK, who from the very beginning of my journey into cavernomas and from the inception of Cavernoma Alliance UK have worked with me, and David, Helen Evans and David White, when he was interim Chief Executive Officer, have both helped, and now Joe Noakes, to really support us in the design and the conduct of this study. And I'll move on to that in a moment. So thank you all. So we're very ably supported by the Patient Advisory Group, and you see those here who've given their consent for their photos to be used. And Hannah and Julie Thompson are representing children and parents on the Patient Advisory Group. I'm really grateful to everybody who put in a lot of work, often at short notice, to make sure that the design of the study and the materials we're using for it have had thorough patient and public involvement. And not to mention the huge amount of work that David White, Helen Evans, Ian Stewart and others have put in preceding that to get us to the point of actually conducting this study. So why are we doing it? And I think this project is a really good example of the modern approach to identifying a research uncertainty that's common in clinical practice, and that's also a priority for patients and the public to determine the agenda for what should be done. So what we did, as many of you will know, is a priority setting partnership, which is a formal approach to identifying uncertainties about conditions, be they cavernomas or cancer, heart disease, whatever. And it's a systematic process. My slides are advancing for some reason, I'm not sure why, but just bear with me on this. The process itself involves identifying all the uncertainties from the medical literature and uncertainties for patients, parents, and the public, and then distilling them down to a top 10 list of uncertainties, which is a method that's recognised by funders in the UK for reliably identifying the leading uncertainties that then should be considered for funding. And you see at the top the photo of all the people who are involved in the very final day of deciding what the top 10 would look like, having distilled all the uncertainties previously. And this is what the top 10 look like, and you can see that the leading question for everybody involved that was prioritized by this process was, does treatment with surgery or treatment without surgery improve outcome for people diagnosed with brain or spine cavernoma? You can see there are many other uncertainties worthy of being researched, but there's only so much time in the day, and what we decided to do was engage in the hugely time-consuming process of developing a research study and an application to address the top question, leaving many others still to be addressed. One or two of which actually we've been doing research on and publishing on in the meantime. So what are the options for people in everyday practice at the moment? And top left, some of you will have encountered neurologists like me who will tell you about the diagnosis, what the outlook is like, manage epileptic seizures or your recovery from a bleed, for example, due to a cavernoma without using surgery. May keep an eye on you, may do further imaging if the diagnosis is uncertain, and generally do things that don't involve surgery. And then there are the other two approaches, and perhaps I'll hand over to Neil at this point just to give you a brief description of those two.
Thanks, Rustam. So first of all, the majority of patients who have active intervention undergo neurosurgery, which is essentially an operation done by a surgeon, in which the cranium is accessed, the brain is exposed, and the cavernoma located and removed, usually under the microscope with very high power illumination, with micro instruments, to delicately, as possibly that is possible, separate the cavernoma from the surrounding brain tissue and remove it from the brain. At operation, just to remind everyone, because you will have read this in the information notebooks, the cavernoma typically looks like a sort of dirty blueberry or blackberry, and the brain surrounding it often has a yellow tinge to it, and that's the hemosiderin. That's a breakdown product of blood which leaches into the surrounding brain tissue. The main issues with the surgery are the two things, really. One is the risk, that is to say, the complications of doing that, and secondly, the chance of not removing all the cavernoma, so leaving some behind. And so even during the patient's post-operative phase in hospital, we know more or less whether there's been any major complications from the surgery, though clearly others will become apparent in the following months. And secondly, we nearly always do a brain scan to determine if the cavernoma has been excised. The hope, of course, being, hope and expectation being that within the complete excision of that cavernoma, that then removes the risk of future bleeding. The other treatment modality, which you will have heard of and which is in this study, is what we call stereotactic radiosurgery using the gamma knife machine. This sounds quite complicated, but basically it's the gamma knife is the machine we use. It's a form of very focused radiation therapy, which given in one sitting. So when it says radiosurgery, there's no actual operations involved. The patient's head is secured either in a frame or nowadays in a mask, and undergoes an MRI scan on the day of treatment, and then goes in the gamma knife machine, and you can see a sort of a photograph there of actually not the most current model, but a previous model. And the machine essentially focuses those collimator beams, which you can see on the helmet, into the target. And so the difference is that this is a day case procedure. It's done under a local anaesthetic. The patients literally come in at 7:30 in the morning, and they can leave at lunchtime. And there's minimal risk on the day. Patients often have 2 pinholes visible on their forehead for about a week, may have a bit of a headache for a couple of days, but essentially that's it. However, as opposed to surgery, the scan will look identical. Nearly always the scan done either, if one did one the following day, which you wouldn't, but if you did, it would look exactly the same. The cavernoma is still there. And indeed, in the months and years going forward, quite often the cavernoma does look the same. Sometimes it doesn't, but quite often it looks exactly the same. And the second point is that any side effects from the gamma knife therapy don't occur immediately. It can take several months for any side effects to come apparent. And that's due to the fact that though this is a non-invasive treatment in terms of there's no cutting involved and so on, the radiation is high dose and highly focused, and the portion of the brain around the cavernoma still does receive some radiation therapy, and that can react in the coming months and give rise to neurological symptoms. which can then last for several months. So it's a different risk profile. So they are technically quite different treatments. And I suppose the default practice in the UK up until now has been to, if active intervention is decided by the surgeon, most of the time, if the cavernoma is felt to be safely accessible and excisable, then surgery would be performed. And only the minority of patients would be referred for gamma knife. And that would be dependent on the surgeon determining that the cavernoma was in an inaccessible place for surgery. So that's a sort of brief summary of where we're at as we stand now, Rustam.
Thank you very much, Neil. So you'll understand that these are the three options that are available in standard practice. And until now, doctors like myself and Neil, who see patients with cavernoma, make decisions according to the best information available from people who've been observed getting on with treatment without surgery, or seeing how people have done in research that's been published about treatment with surgery. But quite a lot of the time we're uncertain about exactly which approach is best. But of course, we make decisions based on the evidence available and our experience and patients' wishes about which option to pursue. So we do the very best we can based on the information available. But Neil and I, in our everyday clinical practice, will deal with people with many other conditions for whom we have a much higher standard of evidence, brain tumours, for example, in Neil's case, or people with stroke of other causes in my case. And in those conditions, we have the gold standard of evidence, a randomised control trial, to tell us whether to use treatment of one sort or not. So we've long struggled with doing our very best for patients because we're making decisions based on our best judgment, not on the best available evidence. And that's where the CARE trial fits in. So that is a research study which is the gold standard. It's a randomized control trial, and I'll come on to that. And so we're really excited for the first time to be embarking on doing a randomized trial of treatments that are already in standard clinical practice, but where we have uncertainties about which patients they should be used for and whether they should be used in some people, and also whether treatment with surgery or treatment with gamma knife should be used. And that's where the CARE trial fits in. So this isn't, if you like, a novel trial of novel treatments that we're really hoping are the next best thing for cavernoma. This is us saying, hang on a moment, people with cavernoma deserve the best standard of evidence available to tell us what we should be doing with these treatments available in everyday practice, whilst also trials are being done of drug treatments and things that are much more experimental. But we feel we should work out what we should be doing in everyday practice in the NHS first. So now we at last have this opportunity to resolve this leading uncertainty. And this really arose from the observational research that many people have been doing over the years to see how people get on with or without surgery. And then our priority setting partnership, which then is specifically considered by the largest research funder in the UK, the National Institute for Health Research, or NIHR for short, who mulled it over for several years after the end of the priority setting partnership, about 3 years to be precise, and finally advertised this opportunity for people to apply for funding to start to address this uncertainty in December 2018. And then after some intensive thinking and writing and planning, we were finally awarded the grant from this UK competition in May 2020, and we began work in September of last year. So one of your first questions might be, are you eligible for Cavernomas, a randomized effectiveness study or not? And all of the 5 inclusion criteria on the left must apply. So we're not discriminating on the basis of age. Somebody of any age can be involved. They must have a certain diagnosis of a brain cavernoma on MRI. And also they need the right clinical history to qualify to be included. And we're basically including people with the two fundamental types of symptoms that are attributable to cavernomas. Firstly, epileptic seizures due to the cavernoma itself. And secondly, people with a stroke due to bleeding or maybe clotting within the cavernoma. In other words, where somebody has developed something like weakness of the face, arm or leg, or problems with speech or vision that can clearly be related to the location of the cavernoma in the brain, and the evidence of fresh hemorrhage in most cases coinciding with that. I'm well aware that patients with cavernomas have many other symptoms, some of them due to the cavernoma and others not. And because it can be difficult to disentangle sometimes whether patient symptoms are due to the cavernoma or not, we've restricted to the trial to these two types of presentation where we can usually be sure that the cavernoma has caused the symptoms in question. Fourth, both the patient and their doctor need to be uncertain about whether they should have treatment with surgery or radiosurgery or treatment without those options. In some cases, doctors and patients will be certain one way or the other, but in many cases, we are uncertain. And if we collectively arrive at that decision, then a patient would be eligible for the CARE study. And provided they have mental capacity to consent for themselves, or an adult in the case of a child is able to provide consent for them, then they would meet all the inclusion criteria. On the right-hand side, you see the criteria that means a patient wouldn't be eligible. So if they've already had surgery, for example, to remove a cavernoma and there's imaging evidence that it's gone, there would be no need to randomize them in the CARE study. If they only have a spinal cavernoma, and they don't have a brain cavernoma that's caused symptoms, they wouldn't be eligible, I'm afraid, because the funder commissioned research on brain cavernomas, not spinal cavernomas. We would exclude people if their cavernoma is deemed to be asymptomatic. In other words, the cavernoma itself has not caused symptoms, and that would need to be judged by the doctor assessing the patient. And finally, we're not including people a second time in the CARE study if they've already been randomized. So for example, if you entered the CARE study, you're allocated to treatment without surgery, and you say, can we roll the dice again? Can I go back in so that I can see whether the second time I might get surgery or not? We wouldn't allow that to happen. People can only go in this study once.
I just add something, Rustam, that this is surgical trials like this are often run on this uncertainty. Let's call it uncertainty principle, and well, I know, and you may know as patients, that surgeons are don't all have the same uncertainty. Those surgeons that everything is black and white. They always know what to do, or don't, or those who are much grayer in the sense of what they are certain or uncertain about. And I think that's the strength of the study is involving a large number of surgeons whose uncertainties are all different. So it's that's the strength, because it provides a real life, real world situation that we're dealing with here. I just wanted to say that, Rustam. Thank you.
Neil. And that can sometimes be difficult for patients, but I think the fact that we've got a well-organised system, we've got Cavernoma Alliance UK supporting patients with their thoughts about the CARE study, and also a large group of people involved in it. I think that those may be issues that we encounter with patients in practice, where some patients find that uncertainty varies between doctors. But I think the fundamental point here is, as Neil says, we should expect people's uncertainty to vary because we're lacking the best available evidence to tell us what to do. If we had that evidence from the gold standard randomized control trial, people would be much more consistent in their decision making about cavernomas. So that's why we just have to do this study. The other bit that's embedded in this study is us understanding about how best to give information to people like you with cavernomas. Because very few randomized trials have been embarked on before for people with cavernoma, we need to understand better about how to give the information about the condition, about the research question, and how to break down any barriers that there may be to your participation, and really facilitate people's participation as much as possible, because without people wanting to participate, there's no chance in us answering the question. We've got some very carefully designed materials, and huge thanks again to the patient advisory group for the care study and helping us with these. And this is an example of 2 pages from one of our patient information leaflets that very clearly lay out the comparisons of treatment without surgery in the left-hand column and then treatment with surgery in the 2 right-hand columns, comparing what's involved in each of those options, what the possible benefits are, and what the possible risks are. And without even reading these boxes in detail, you can see that if you compare what the benefits and the risks are in the left-hand column, treatment without surgery, to what the benefits and risks are in the 2 right-hand columns, treatment including surgery, you can see that really they're very similar. So although the treatments themselves are quite different, as Neil nicely explained earlier, overall, over time, the benefits and the risks of these treatments are similar in many ways. But there are obviously fundamental differences between how neurosurgery works and how gamma knife works. So
can I say something, Rustam?
Yes.
That it's Rustam sort of understated the difficulty sometimes in getting a patient information sheet or a participant information sheet like this that everyone's happy with. And I think we're totally in the hands of Cavernoma UK for doing this, and it's a tremendous, immediate example to me of how we are absolutely in this trial together with Cavernoma UK, and it was fabulous to see that your input in developing that.
Thanks, Neil. And as the patient advisory group knows, wasn't always easy, but
no.
and that's no complaint. That's how it should be. But we're here as medics and a trial group to be challenged, and we don't know best about these things. So for us to combine our knowledge about the condition, our knowledge about how to run trials, with your perspective about the condition, means that we need to meet in the middle somewhere, and ultimately we did. So thank you. The reason we're doing this randomized control trial is fundamentally because it's the perfect design for us to work out whether treatment of one sort is best or not, because it's really fair. And the process of this random allocation, where neither the doctor nor the patient decides which of the 2 arms of the study you go into, that process of random allocation, as you can see here, creates 2 groups of people who are perfectly alike. And that's the really important thing about this design. If you look at studies that have not involved randomization in the past, people who are treated for their cavernoma tend to be at least 1, if not 2 decades younger than people who are not treated. And there'll be various other aspects about them that bias doctors towards selecting treatment for one type of person or another. So the randomized trial takes people who are uncertain about whether they should have treatment or not, splits them into 2 groups, one by one as the patients come along, and allocate them at random to one group or the other, such that by the end of the trial, if it's big enough, you have 2 groups of people who are perfectly alike, other than the fact that one group gets surgery and the other is treated without surgery. And then over time, we follow people up in exactly the same way. Everybody gets a brain MRI scan at 6 months, and everybody answers the same questions about how they are, whether they've had any further strokes or seizures and so on, at set intervals, 6 months and then 6 monthly thereafter, for as long as we're able to continue the study. So this is a beautifully simple experiment, although tremendously complicated to organize and to do. But at the heart of this act of random allocation is what really will make us able to do the best study to answer this question. And if you want to find out more about why randomized studies are so important in medicine, then if you visit this website, www.testingtreatments.org, you'll find this fantastic book, which has been written in plain English for patients. Sorry about these slides advancing, to describe to you why trials are so important. I think this is a great read for anybody who's interested in this in more detail. there's also this video which very nicely describes why randomized trials are the gold standard for informing us about treatments. And in a short video, which you can probably see playing here now, and it carries on to tell you in about 5 minutes about why trials are so important. So I'd recommend that, and I'm happy for these slides to be shared after my talk. And we've all lived through a really unique time in our living memories of a global pandemic. And the real game changer is not the sort of nonsense that Boris Johnson's been talking about over the last 18 months, but the real game changer has been here, as you all know, have been the randomized control trials that have been run from Oxford that have really given us the knowledge that we need to know how to manage patients with COVID-19 better. So from the very first result in December of last year, when dexamethasone was proven to be the first life-saving drug, that was from the recovery trial, and then tocilizumab also was found to be the next drug that cuts deaths from COVID. And only a couple of weeks ago, there was this specific antibody that was given to people who lacked antibodies against COVID-19 that again was found to be life-saving. All three of those came from the same randomized control trial, recovery, and have saved probably millions of lives. And then finally, I was a participant myself in the Oxford COVID-19 vaccine trial, the AstraZeneca vaccine trial, which was amongst the earliest after the Pfizer vaccine to demonstrate effectiveness in preventing COVID-19 death and severe infections. And I think it's only right that people like me who want to improve the way we care for patients by doing randomized trials should also submit ourselves as guinea pigs to take part. So that's I think the least I can do is practice what I preach. So I just wanted to you to know that I have already been randomized myself. And I think I felt the benefits from being in the trial regardless of what I received. So the objective of the CARE study is to show that a really definitive study to completely answer this question can be done. And the reason the funder has really wanted us to demonstrate, first of all, that the study can be done is because it's probably going to take an international trial to definitively answer this question. And we don't think that in the usual funding time window that a grant-giving body allows grants to run for a trial, which is usually 3 to 5 years, we don't think we can do it in the UK alone. There aren't enough patients. So we're on this timeline, as you can see, where we've got pretty much all the relevant regulatory approvals, and we've been going around the neuroscience centres in the UK and soon the Republic of Ireland, I hope, to train them in the process of the trial and then lead to their hospital opening so that they can randomise patients. We were hoping recruitment would begin this month, but there are a couple of impediments to that. One is that our trial database hasn't yet been finished to enable us to randomise patients, and the other is we're waiting for one final bit of regulatory approval. We're in the process of trying to get regulatory approvals in the Republic of Ireland, which have been slower, but the rest of the UK is covered by the same regulatory approvals from ethics committees, which we have. And then we're planning to recruit people until the end of November 22, follow people up for at least 6 months, May 23, and then the trial itself ends later that year. And at that time, we hope to be in a position to show that we've recruited enough patients at these 42 sites to show that a definitive main phase trial or study can be done internationally, and that we also have good buy-in from our international partners, some of whom are on the call today, both professionals as well as patient support groups and funders, so that they can all invest in the conduct of a trial that learns from the CARE study and becomes the definitive CARE trial to tell us how to manage patients in the future. So far we've already been in this sort of format, Zoom Teams, around 10 sites where they've done our structured training on the web, and then we've had a meeting with them for up to an hour and a half to make sure they fully understand the processes, to understand how patients are treated with Cavernomas at their sites, and then get all the regulatory approvals in place for them to start. We've got several other sites left to work through, But in the meantime, you can find information about all those recruitment centres that you see highlighted by red pins on the map to the right via our study website, ed.ac.uk/care-study, nicely laid out website with lots of information about the trial. You can find the patient information leaflets there. And enormous thanks to Cavernoma Alliance UK for your support, and also for the web pages now about the care study going live on your own website. You see the URL at the bottom there, and these are accessible via the homepage. Really nice looking web pages, full of useful content for you that complements what we have on the trial website. So really our trial website and the CAUK pages are complementary in this respect, and you should find all the information you need there. But if not, always contact Cavernoma Alliance UK, where you'll be able to have a discussion with them about it. So that's all I was going to say in my presentation.
Rustam, could I just add something?
Yeah. That's
just reassuring to those on the call that every single neurosurgical unit in the UK is taking part. So it's not as if you've got to go to another unit if you want to be randomised or think you're missing out, or your local neuroscience centre are participating in this study.